Infertility in men. So most of the times, my experience is that when they come to the clinic and they're doing an initial consultation, the vast majority of men, they are not aware about their fertility. So essentially they're coming, they're looking for advice. But of course, when we get into the point to, okay, have you had a Sim assessment to see motility, sperm concentration, and all the parameters, vast majority are saying, no, I haven't had one of those. So then we start from there. And then, well, it's kind of common to have different problems there, like low sperm concentration, motility. But I would say that a really good percentage of patients, they haven't had any assessment at all. So what are your thoughts?
I think there's sort of a wide range of causes where most of the time it's hard to pinpoint a specific cause unless they have a clear sort of genetic condition or if they've suffered from mumps in the past or something like that.
Yeah.
Whereas most of the time it's just a combination of lifestyle factors and things like inflammation and anything that you can do, like drinking, drug use, all those sort of things that all just add together to have an impact.
Well, yeah, that's the thing about 30% of the male fertility has a genetic background, but the rest of 70% is just environmental causes. So it's a very wide range. You can have mechanical injuries that then transform into varicocele and all other stuff. As you said, mumps if you get it in adulthood. So plenty of causes for male fertility.
So it will be fair then to say that we will say that the most common will be undescended testicle, mumps, and then some genetic conditions. But then all of them, they will not cover like 80% of the causes. That sometimes we just don't know as well, right?
Yep. So there's like environmental factors in the world we live today with plastics and things like that have an impact. And around 30% of cases of infertility are completely unexplained, so there's no test to identify exactly what the cause is. Which is where it comes down to sometimes you could have a perfectly normal semen analysis and still be deemed as infertile because there's a lot more to sperm function than just being motile and high concentration. There's a lot of chemical and processes that need to take place.
I do have a question for you. What do you think is the role nowadays for the DNA fragmentation? So what are your thoughts on that one?
Well, DNA fragmentation has also, all sorts of causes. So one of them can be exposure to toxicity.
Yeah.
So I don't know, men working in the agriculture with all sorts of pesticides and all sorts of chemical substances. Men that work in plastic carpentry, that get a lot of small plastic particles in their body. I saw some correlations with DNA fragmentation. But DNA fragmentation is basically, it's not necessarily a DNA denaturation.
Okay.
It's just the way that the DNA is packed. So in sperm, compared to any other cells, the packing of the DNA is done by different proteins called, they're not histones like in every other cell, they're protamines.
Okay.
So basically those are proteins that have more sulfur in them as a element. And you can get DNA fragmentation even if you have carriers of some of these elements. So it can be exposure, but also it can be something related to overall metabolism.
Okay. So you see, there's kind of several kind of DNA fragmentations technique for checking.
Yes.
You have the tunnel, the comet, whatever. What are your thoughts about those, James? What do you think is one that we can recommend? What do you think is it's a good investigation to do?
Quite a few different types, and they all measure the strand breaks in the DNA in different ways. So like Julian was saying, the DNA in sperm is packed in a different way than it is in somatic cells, where it's more of a tight crystalline structure, and that's to make sure that there's not much biological activity going on in the DNA that can cause mutations or alter the DNA, because that's essentially the package that the sperm is trying to deliver to the egg. So in terms of the different types of DNA fragmentation tests, there's a lot of research going on at the moment, and it's proven very hard to standardize methods across a sort of worldwide consensus to work out what limit of DNA fragmentation is healthy or not, because every male will have DNA fragmentation in his sample, but it's at what point does it start becoming an issue that's hard to work out. So the different tests work in different ways, and there has been meta-analysis done to work out that it seems like maybe tunnel analysis has the highest correlation with predicting miscarriage.
Okay.
Which is essentially where once the sperm and the egg have met and the embryo is formed, it takes a few days before the sperm DNA begins to kick in to the development of the embryo. So it would make sense that a sperm fertilizing an egg that has fragmented DNA could lead to, it could still conceive and produce an embryo, but it could likely lead to a miscarriage.
Yeah. My main thing with the DNA fragmentation, and correct me, Julian, if I'm wrong or not, but the thing is, like, we are testing one sample, okay? So what not necessarily means that all of the samples they're going to be kind of being on the same. So what is how reliable is the investigation, regardless if it's the tunnel, the comet, whatever? So what are your thoughts on that? So sometimes the question is like, oh, Alex, should we do the DNA fragmentation to everyone? So what do you think, Julian?
Well, this is like the DNA fragmentation. It's more constant than the rest of the semen parameters. So like DNA fragmentation doesn't necessarily change from one ejaculate to another.
Okay.
But when we talk about common parameters that we measure in semen analysis, motility, concentration, they're very much variable. Like not very often you find two exact semen analysis from the same patient after a period of time.
Yeah.
So it has to do also with period of abstinence.
Yeah. So
they were trialing a couple of years ago for high DNA fragmentation. They were asking the male partner to ejaculate every day, even though the counts obviously they were getting smaller, but they would have lower degree of DNA fragmentation. Now, also DNA fragmentation can happen in the depository area of the testicle, in the epididymis. So the longer the abstinence period, the higher the concentration of DNA fragmentation you'll have.
Okay.
Because basically, normally, a normal ejaculatory program, let's put it this way, would be somewhere every third day.
Every third day, okay.
So every sperm that gets to sit in the depository more than 3 days might get affected by the DNA fragmentation.
Fine. Okay, so and then what would be our advice here for patients? Should we just advise them like kind of having a short abstinence period when they're coming to
3 to 5 days, I think, is the general consensus. If you leave it for too long, then sperm cells can start to break down and be reabsorbed into the blood, or you would have higher concentration of sperm cells in your sample with a longer period of abstinence, but more of them would be immotile and have poor morphology because they degrade over time. So that's saying in the epididymis.
And also the ones that die during the depository period, they eliminate oxygen reactive species that actually, is one of the causes of DNA fragmentation. Well, I would recommend to get it before they actually start trying.
Yeah, so it's an interesting question, but I think I do agree. I mean, if there's a couple that they're kind of trying to conceive, it would be the sooner the better. It's the same advice as for women. I mean, the sooner that we know about what's going on with the sperm, I think the better we can just kind of prepare something or advise the couple better. So that would be my recommendation. Definitely there's some kind of guidelines, okay? So if one couple been trying for less than a year and that particular couple is under 35 years old, well, you potentially can wait a little bit more. But if it's above that age, which is pretty much the vast majority of the patients that we're seeing or couples that we are advising, so yeah, it would be ideal before the starting. But if they already started and it's more than 6 months, I definitely would recommend to do a semen assessment.
Yeah, it would definitely make sense to get it done before.
Yeah.
Particularly for women, because as they age, their ovarian reserve is constantly undergoing mutations and changes in the egg DNA, which can lead to further problems down the line. Men still have the same factor in terms of age, but not quite so much because they're constantly producing new sperm cells throughout their entire life.
I agree.
The drop down is not so abrupt after a certain age. But my answer was more related to like male management perspective of reproduction. I mean, most of the couples already know, like they agree that they want to conceive. So from my perspective, a male should have a semen analysis done even before that, because if there are issues, as we know, the time to produce a sperm cell is somewhere around 65 to 72 days. So everything that happens in those days can contribute to improve or lower the quality of the sperm. So there are certain things that if you get the trigger alarm, you can start looking after solutions.
I can agree more with you. And the other thing is, like, what I always say to my patients there is, like, you see, when it comes to do an investigation for women, regardless if it's just a scan or doing a blood test, whatever, it's more invasive. Whereas for men, we should start always with men. You see, producing a sperm sample is not painful, okay? It shouldn't be, at least. So that's the reason why we advise always, as you were saying, just trying to get that first as possible. Yeah.
And in fact, you can produce a sample at home to bring it in for a semen analysis as well.
True.
Which really makes it
much
easier for the male side of the investigation.
Well, we're way more lucky than the women in this field. Like every investigation with the women are invasive.
Exactly. Yeah.
For us, it's not much of a job. Let's put it this way.
Well, you see, the last thing that I read about that, there's no full evidence on that. There is strong evidence that is supporting that. I might be wrong, but I read that a few weeks ago still, and I mean, you are experts as well, so I don't think that their evidence is there. What do you think?
Especially not with sort of mobile phones and like 5G and things like that. There's no evidence for that having an impact. But I would say, certainly from animal models at least, there's evidence of heat having an effect. So if you constantly have a hot laptop on your lap, it could have an effect. There's no empirical definite evidence for that in humans, but
well, the biology says that the reason why the testicles are outside the body is because they need to be cooler than the rest of the body. So actually the temperature in the testicles should be around 35, 36 degrees, so 1-2 degrees lower than the rest of the body. And indeed, it's very hard to get, like one certain reason why the semen quality drops. Unfortunately, this, like laptop or like sitting on the chair too much, these are adding, everything adds up.
Yeah.
They're lifestyle factors. You can't really, there's no way to measure one of them. You can't just like, you don't have a control population to say, like, okay,
that's true,
you're gonna stay 8 hours in that chair and you're gonna eat all the same and you're gonna have everything the same, but it's definitely contributing. So
absolutely.
Everything that has inflammatory action, that's dropping down the quality of the sample, both in counts, motility, everything.
Yeah, what's your position about vitamins or supplements? Because you see, I heard recently as well that, okay, so DNA fragmentation, we treat most of the time with vitamins, but I also heard recently that having too much of vitamins actually can be detrimental of the DNA fragmentation. So what do you think about that? So,
well, there are very few vitamins or elements that don't have a negative effect if they're in excess. Like iodine, for example, is one of them.
Yeah.
But the vast majority, it has to be balanced.
Yeah.
So my personal perspective on supplements is, okay, do you have a deficiency in something? Yes, you get that might help.
Yeah.
But if you don't have it, I don't know if it improves or not.
There's not really been any specific ones that have definitely been shown to improve male fertility. I think common ones are like zinc supplements and folic acid and things, but when you look at the studies, some of them go one way, some of them go the other.
Okay.
Well, the reason why they go one way or the other is because when you ask patients to start those supplements, you're basically changing their lifestyles. Yeah. So you're not, you can't assess just the supplement. Yeah. You have to assess more. And it all begins multifactorial, and you can't, attribute this factor is 0.9 of the whole.
Yeah, it's very hard to produce an experiment that standardizes for one specific factor that affects male fertility because everyone's doing so much so many things that would have an effect on it.
Yeah.
But definitely, some blood works, they indicate like lack of iron, lack of zinc, lack of, or suboptimal levels. So definitely, supplementing those would be beneficial.
Improve your lifestyle over a long period of time. It's no good just sort of switching up and starting to live healthily 2 weeks before a semen analysis, because as you said, it takes around 75 days for a sperm cell to be produced. Saturated fats, big thing. Your diet, Mediterranean diet, is supposed to be pretty good for it, whereas the Western diet, not so much.
True.
Smoking, drinking, anything that causes inflammation are the main things.
Sometimes I do have couples, of course, that the main problem would be infertility, okay? Concentration, motility, whatever the factor is. So it's funny because sometimes when they're coming to the office, it's like a female patient, of course, they're saying, Alex, but I'm completely fine. So what should I do on IVF cycle? So what should I go to? And the way of what I'm just always telling them is like, okay, this is a teamwork, okay? So I think the way of supporting men as well is to be very, very honest and open with them, telling like, hey, if we want this happens and works, so we need to be together on this. So yeah, it's on your side, all is good, but in order to get pregnant, you need also a healthy sperm there. So this is the way of supporting that couples, I think, is just like giving all the information, being very honest to them, and just advising what is the best treatment for them. I think also men, we do suffer of pressure. I know that is, as you were saying, like it's not too much work to do when it comes to producing the sample, but at the same time it could be very stressful too, because it's like, oh, I need to perform, you see? So I think the way of supporting couples is just being very honest with what we need to do and just telling them, well, we are all going to be here trying to do all of us our best. So what do you think?
I think it's also important for patients to understand that even if they have a very poor semen analysis and male factor infertility, there is still very much possible with the treatments available to isolate the good sperm cells with the good morphology and motility and specifically inject those into an egg. So a poor sperm sample nowadays isn't the end of a person's reproductive journey, and you can...
Yeah, that's a really good advice, yeah.
Because I think a lot of patients, if they're coming into it without any prior knowledge of what's available in IVF clinics, then they might not understand that we can work with very poor samples.
Okay. Yeah.
Well, I actually agree with your idea that men suffer as well on this and the stress associated with this. So I can tell you, fun fact if you want, 80% of the semen of the samples that we use for clinical cases are worse than the previous semen analysis.
Are they?
Okay. So they come, they do semen analysis. The sample is what it is.
Yeah.
When they come for the treatment, the sample is worse pressure. So it's exactly it. They feel the pressure. It's not it's not an easy thing to realize that as a couple the only issue is male infertility. So definitely the partner support should be there because because there's no other way around.
And then another big factor for a sperm sample as it's being produced is level of arousal. Has a huge impact on the quantity and amount of sperm that is produced in the sample. So.
Fresh or frozen samples? What are your thoughts on that one? It's a very common question, Alex. To teach, we need to freeze something in advance just to be 100% sure that on the day, or it's like, no, fresh is definitely better. So I want to hear from you guys.
Well, what's your opinion?
I mean, fresh is definitely better if it's an option.
Okay, it is an option. Okay.
Freezing and then thawing sperm, there's always going to be some of them that die from that process because unlike eggs and embryos where you can replace the water within the cells to a bigger extent, which allows them to survive the freezing process better because the freezing solution keeps them alive, whereas in sperm there's very little cytoplasm, so very little water content, and it leads to a lot more of the cells dying from the freezing and thawing process. So it would always be better to have a fresh sample if you can, but again, if you're undergoing treatment for cancer or things like that that you know is going to have an impact on your sperm, then it would be a good idea to get some frozen.
Yes, well, even though the data shows that the rate of pregnancy it's higher fresh compared to frozen overall.
Okay.
I still see freezing of sperm as a method of selection. So basically, because the sperm cell is too small,
okay, interesting.
You can't really investigate what's inside it. Okay, so you can do, as we spoke, the DNA fragmentation, but we can't really see, other than we see at the microscope. So for me, I can see it as a selection tool. Like whatever is not surviving.
It wasn't good anyway. Yeah.
It wasn't good anyway. Even though it should have, probably had good morphology, probably had good motility.
That's a good point, because with humans, the way that we've evolved our sperm and reproductive systems, it's much more of a system of quantity over quality, whereas in animal models it can be different. But for humans, only around 4% of human sperm cells actually have the correct morphology and the right shape to get the job done.
Yeah.
So if you consider that during regular intercourse you could have like 100 million sperm cells being deposited into the vagina, then you would only have around 20 that would actually reach the site where the egg is fertilized. So you have this natural selection process as the sperm cells would navigate through the female tract. So like you say, it's good to have systems like that in place in the lab, say freezing, survival of the fittest, whichever cells can survive that are more likely to be the ones that would fertilize the egg normally.
Excellent.
So patients have the option to produce a sample at home and bring it in, or we have rooms available at the clinic where they can produce the sample. So we take the sample into the lab and we allow it to liquefy for at least 15 minutes, because the semen, when it's freshly ejaculated, can form a sort of coagulum because of proteins which are supposed to break down from the enzymes in the prostate, break down, and it makes it much less viscous, and it's a good sign that the breakdown can happen it's called liquefaction. So it's supposed to happen in around 15 minutes.
Also, the assessments start with this as well, right?
Yeah, so that is part of the assessment.
Okay.
So the liquefaction, you look for that because it shows the presence of the function of the prostate enzymes that should be in the ejaculate. And then once that happens, we measure the volume and the pH of the sperm. So it should be slightly alkaline because of the seminal vesicles and their contribution to the ejaculate. From there, we look at the concentration of the sperm cells, which is measured in millions of cells per milliliter.
So you're using the macula or whatever, right?
A macula chamber, which is essentially just a small glass square grid, which allows us to count how many cells per milliliter because of the set volume in the chamber. So we look at concentration, motility, so how many of the cells are swimming and how many are not, and the type of motility that they're showing, so they can be twitching on the spot or moving slowly, quickly, and there's also a hyperactivated mode of motility, which is where they're zigzagging from side to side, essentially, which is a good sign because this.
So there's a grading regarding that, right?
Yeah. So it's a grading system laid out by the World Health Organization.
Okay.
We also look at morphology, so we look very closely at the structure of the sperm cells, and you're looking for at least 4% of the sperm cells to be normal morphology. And we also do sperm antibody tests, which are essentially little beads which assess sperm for whether there are anti-sperm antibodies in the semen, which can also be present in the female tract, and it suggests that there could be immunological attacks of the sperm, which could lead to infertility in itself.
Okay.
So it paints an all-around basic picture of the
How long does it take, James, to do an assessment?
Around 15 to 20 minutes, I would say, to do a full basic semen analysis.